I just completely disagree.
It's fact. It's known fact.
I don't think that's true.
It is, so I don't know what to tell you.
All right, well, Mom said you were an accident.
What?
Everybody, welcome to Sights and Sirens Back to Basic podcast. Today, our sponsor is CPR for All. CPR for All is a non-for-profit organization based out of Oregon that does CPR training for lay people and for the community. And obviously, they try their best to do it for free, which is awesome. I think it's a great mission. And kind of a fun fact is that they're a non-for-profit organization. Obviously, we're a for-profit organization, but we don't make any profit. So,
right.
Yeah, it's a very similar.
So it's kinda,
yeah,
we share that.
Right, exactly. So, Jason, why don't you introduce today's topic? This is an exciting one I'm excited to talk about. So tell us what we're going to be diving into today.
Nice.
See,
we're going to be talking about scuba diving emergencies. So I think that we cover a lot of environmental emergencies, especially in our programs and in our live lectures and things like that. I would like to go a little bit more specific into scuba diving emergencies specifically, because I think it's kind of, glazed over a little bit, and we can kind of, it takes a little bit of understanding of the science behind diving and the science behind what goes along with diving to really understand the illnesses that can show up and how then we treat them.
And it's not easy. I don't think it's necessarily something that's intuitive. It takes some time to really figure. It took me a long time to figure out exactly the pathophysiology behind diving. So I'm excited to talk about it today because it helps me even remember, oh yeah, that's why we do certain things.
We're not going to be giving anyone a PhD in physics or pressures or anything like that. Like we're going to keep it simple. We're the Back to Basic podcast. We'll do back to basic stuff with it. But hopefully after today, people can have just a little bit better of a grasp of what's going on when we're down there, and then what happens when we come up possibly too fast or in the wrong way, and what we can experience. So you and I are both scuba divers, as a little bit of background. Do you have advanced or just?
No, I just have my open water.
Yeah, so you have your open water cert. I'm a certified dive master,
right,
which just means, sounds fancier than it is. I can like help teach and stuff like that. And then I've been through some rescue diving.
But that's why I have to call you master when we dive, right? Or
there's just other reasons.
What?
No. What's funny is I hold this dive rescue certification, and I use it on my resume and stuff. I work in a city that has no bodies of water. Like we will never need, besides like outside of Meyer, like the little retention pond. Like, there's no reason I would ever need to put scuba gear on. But
that's cool though.
It was a fun thing to get.
Well, and the training makes a huge difference because even when I dive with you, you can tell. I mean, like I've dove with other people before, but when we dive together, I literally feel safer. I mean, like you just dive in a way that you have things that you're thinking about and that are on your mind that makes the whole experience more relaxing and fun. Because it obviously, if something goes wrong, it goes wrong in an environment where this is.
I'm glad you think that, because we've done some really stupid stuff out there.
So
for our audience, we'll just give one example. Chris and I were one time diving a sunken plane at night. It was the first time either of us had dove at night, I think, at all. And all of my lights went out. And instead of being like, oh man, it's unsafe, like you can't see anything,
right,
but Chris's lights were on. So I just swam to Chris, linked my arm on him, and we continued the entire dive.
Like tandem dove together, like linked
which is really not something that you should do ever, or I recommend.
That was a scary thing, right? Because I was at the back of the plane and you were at the front of the plane, and I just see your light. It's pitch black. It's the middle of the night. We're not diving in the Caribbean. We're diving in, Lake Michigan waters. I mean, it's dark and kind of murkier anyway, so I only see your light at the front of the plane, and then everything goes black,
just disappears.
Yeah, you're just gone. I was like, okay, well, and I just waited there, and then all of a sudden, like a little while later, like in my little vision of light, you come swimming by, just like, and then like I said, you just like grab my arm, and I'm like, okay, let's do it. But yeah, so probably not the smartest idea, but with your training, like I said, we both have been diving for a while, and everything was fine. But you've also, so real quick, just to share one other story though, you were diving with our dad, and someone surfaced dead, right? I mean, pretty much.
Yeah. So it was the first time Dad had ever dove recreationally. So our father had some experience as a rescue diver in his time in the fire service. But rescue divers, at least the team he was on, basically they would just like tie weights to themselves, sink to the bottom, and they were basically searching for bodies. So he didn't have any like skill. I mean, but no, you didn't have any like practice in like buoyancy or like recreational diving, like how you would dive.
Right.
So he was a little bit nervous about it because he's used to having like an O2 line that's attached to him from a boat and like constant communication through like their sweet helmets and all that. So he was just a little nervous, and I kept being like, "Oh no, nothing happens. Like it's super safe. Like I got you," sort of thing. I already had open water at this time, so we go on our first dive. And we surface, and he's like about to be like, hey, like that wasn't so bad. I feel safe. And we hear like a whistle go off, and this guy had basically like had a heart attack and drowned. And they're going, is there any medics in the water? Is there any medics in the water? And we're both like, oh no, here we go.
Right,
so like 45 minutes later of like grueling
this
CPR.
This guy had been diving.
Yeah.
So he like had hard. You think
They like
he had a heart attack.
had a
while
hard time
diving.
pulling him out because of all that gear. So they pull him out. I think we figured out after like case they told us heart attack, but he had like had a heart attack, drowned down there. Then they had pulled him up. I can't imagine being in that situation. But then
wasn't he
pull him up.
diving with his son too? Or something?
Yeah, it was. Like
So
his
dad is
family.
thinking,
yeah, like what the hell is?
Well, and you guys, and if I recall correctly, you guys did CPR for like 45 minutes.
45 minutes
because
like,
you had to wait for the
hottest day
helicopter
of
to
summer
come
in wetsuits. It was miserable. Yeah,
because you were diving. So this kind of brings us to like the first thing is that whole scene consideration stuff because this person had to be flown out. Obviously, there was no EMS ground transport. So
yeah. So there's, I think if you ever get dispatched to a call that's a potential water involved or scuba involved type of emergency, there's some considerations just to make right off the get go, right?
Sure.
So we're dealing with potential, like you were mentioning, there's special hospitals that we may have to go to for certain illnesses. So decompression sickness, and we're going to talk about it quite a bit, but decompression sickness or decompression illness is one of the big concerns about diving. And the only solution to that is to get into what's called a hyperbaric chamber. And we'll talk about what that does. But those hyperbaric chambers, they're not at every hospital, right? So you have to be kind of familiar with where's your nearest hyperbaric chamber. And really divers should, and dive teams, like if I go
That's
with
a good
you,
point,
I have an
yeah.
idea of where the nearest hyperbaric chamber is. Like we try to keep track of that. You do that for me too, right?
Of course.
Because you see like this is no, but like
absolutely.
and
Let
like-
me just
like,
Google something really fast.
insurance companies don't cover like diving injuries because it's a high risk. So a lot of times, like if you like buy DAN, which is like Divers Alert Network insurance and stuff, like they hook you up with that kind of contact, and then you can call that place and they can figure it out. So there's like emergency numbers, but you should be hopefully doing your due diligence and know where the nearest hyperbaric chamber is. If you're an EMS agency that or a local hospital or anything like that, like be aware if you have a hyperbaric chamber, if the nearest hyperbaric chamber is in your response area. If it's not, but you have a quarry that people dive in often or something like that in your area, you want to be familiar with, okay, we would have to helo this guy out. We would have to go to University of Michigan. We'd have to go way out there to get it. But,
Well, so that's the thing. So two things. So one, you don't not every dive emergency needs a hyperbaric chamber, but like in the most extreme circumstances you would. So knowing where that is obviously is super important. The other thing is that like people may not realize this, that most of the hospitals that have hyperbaric chambers are the larger hospitals, and most of them are more inland, at least in our area. So like we're based in Detroit, Metro Detroit, Michigan area. So like our hyperbaric chambers are not near the Great Lakes.
yeah,
They're like more,
and they're not.
so,
There's not as many as you'd think. Like
No,
like
right.
some there's some states that have like less than 5 in the state.
Yeah,
so
yeah.
a lot of times we're talking about law and transport.
Well, and I think Michigan might only have like 2 or 3. I don't know.
The last I looked, but I don't know with the Beaumont systems now, and then
Yeah.
a lot of like we're in a little bit of a hospital belt. I know, I think U of M's hospital has one.
Beaumont has one.
and Beaumont has one. I know that for sure. I should do some
Yeah.
better. But anyway,
But yeah, they're not like every hospital doesn't have one by
Right.
any means because they don't get used very often. The only time they get used is for severe dive emergencies, which are rare. I mean, they're a rare circumstance. It's one thing that we want to talk about because sometimes it's worth practicing and talking about the things that happen less often. Talk about them more often, right? Because
Right.
it's actually interesting because you just did an OB lecture last night for some of our students, and I had a dream last night that I delivered a baby because you just like these things that you don't do as
it's
often.
practice how you play, right? And like,
Right.
get used to those like low incident, high risk type scenarios. Like that's why we train on those because you're not going to bump in. No one's got a bunch of experience. No one has got a bunch of experience with dive emergencies. They just don't happen that often, right?
Yeah.
So, I'm sure I'll be challenged. Internet, go ahead and challenge me on that. I'm sure
Right.
someone does, but you know what I'm saying.
Every
it's a rare
person
thing.
that I dive with has died. We're like, wait a second.
I have saved 100 people
From diving.
So anyway, so yeah, just some of the special considerations we need to make. Do you know where a hyperbaric chamber is? could there have been comorbidity? Like, I mean, like, is there drowning involved? Because, right, if we have an emergency down below, like, obviously drowning is one of our biggest and most common concerns, just extricating it from there. Do I need a special team, right? A basic paramedic EMT isn't trained in, hey, I can jump in there and get them out, right? So we're talking about dive teams, recovery teams, like lifeguards, any of those types of situations. And I think just exposures in general, we're dealing with a lot of equipment, especially with freshwater diving. So I think it goes hand in hand. With freshwater diving, we're usually dealing with a lot of equipment that can be hard to get around, right? So cutting through those wetsuits, and we got heat, basically heat dangers when you're sitting in the wetsuit up top on a summer day, and then you've got hypothermic dangers when you've been down there and now you're exposed to the water. So it's kind of both. And then with the less gear in saltwater and more ocean-based stuff, well, now you have the ocean you have to deal with. Right. So now you're talking about, creatures that you're going to bump into that can be dangerous, traumas, major transport times just to get them out of the water. If you're diving on a reef that's 10 miles out, that can be difficult. So just things to consider when we're getting into it. But like I mentioned before, drowning is a big concern. So before we get into specific dive injuries, I do want to talk a little bit, and maybe you can explain to our audience here a little bit about the mechanics of drowning, because I think a lot of times we just look at it as, it's asphyxiation, like it's just lack of oxygen, and that's what drowning is. Or, hey, my lungs fill with water. We don't really understand, I don't know if you call it pathophysiology, but the pathophysiology of the drowning mechanics. So can you go into that a little bit more?
No, absolutely. And I think that sometimes that when we think about dive emergencies as emergency personnel, we're thinking of things like we'll get into later, like decompression sickness and pulmonary embolism, these kind of things, where the reality is that you're more likely to drown while diving than anything else, right? I mean, and actually this kind of hits close to home. Lindsay, my wife, and I were diving in where were we? Bali, Indonesia, and she's a pretty good diver, but it had been a while, and it was some really rough water and really rough sea, and she got into a situation where her mask came off, and all of a sudden she's down and so like I said, drowning became the concern, right? So it used to be that like a situation like that, like, she surfaced and she's coughing up water and that kind of thing. We call that a near drowning. Then we used to designate things as like near drownings and dry drownings and wet drownings and half drowning. We used to have all these different designations. We've kind of gotten away from that in emergency medicine because the pathophysiology is the pathophysiology. Like saltwater, freshwater, there are some nuances there, but from an emergency standpoint, it doesn't really change the fact that the thing that's happening is kind of the same. Drowning is drowning, right? So we're just calling everything drowning now. And some of that is we're doing that because when I say, there was a near drowning versus someone who drowned, what do I mean by that? So like the definition can change. Yeah,
like are they dead because they drowned? And like that's what we're calling drowning? Right. Or are we saying, because if you have a near drowning or you inhaled some water, there's still a risk of having major medical issues later and dying.
Right. And that's why we changed the definitions a little bit, because if I say near drowning versus drowning, I think our head immediately thinks, near drowning is not as serious. What we found, though, is that the complications that happen after the fact are just as serious in both situations. So if we call everything drowning, then we approach everything from a
worst case scenario, sort of like better safe than sorry.
Right, the same standpoint. Yeah. And because definitions, the more definitions you put out there, the more confused people can get. So if I say drowning, do I mean what you mean when you say drowning? You know what I mean? So now it's just, everything's kind of drowning now, just so that people understand that. So drowning is drowning, whether you are unconscious or lost pulses or choked, all that. We're just calling everything drowning now. So the kind of the what happens with drowning, there's a couple, the big thing is that hypoxia, right? So you're not getting oxygen. Makes sense, right? So there's submersion and immersion, where like submersion is where your whole body and head is underwater. Immersion is where just your head's underwater. Why it matters?
Like a swirly?
I don't know. I have no idea why it matters. Right, so there are these like weird definitions, but bringing it back to basics like we like to do, drowning, the main problem with drowning is hypoxia or hypoxemia, if you mean like lack of oxygen in the blood. So typically what happens, and this is kind of interesting, so when you start to drown, there's usually a panic phase to begin with, obviously. It's not like you all of a sudden like slipped into drowning and didn't realize it. You know what I mean? So unless you like hit your head and were unconscious. So the panic phase, your body starts to breathe abnormally anyway, which becomes part of the problem when we start to try to not breathe underwater. Like you hyperventilate and start having these abnormal breathing patterns to begin with. So you're already lending yourself to a hypoxic state because you're not breathing the way you would normally.
Sure.
If that makes sense. Not that it really matters in the big scheme of things. So then what happens is obviously like we hold our breath, right? We're under the water. You know, we're not going to take a breath. We're conscious. But you get to this point where we have what's called air hunger, where your body no longer can tolerate you not having oxygen.
It has to breathe.
It has to
mechanically
breathe.
has to breathe.
Right.
It's
So your body forces you. Exactly. So your body forces you to take a deep breath. Well, as soon as you do that, you're submerged in water. So water enters into the, larynx, airway, that sort of thing. And immediately what happens is you get laryngospasm. So your larynx just closes up. So it's like your body forces you to breathe and then realizes that, oh, this is water. Nope. And it closes the hole basically. So you don't really inhale as much water as you'd think. I think I'm going to botch these numbers, and it doesn't matter for people, but just it's like, 3 milliliters, which is a very tiny amount per kilogram, is the most you can really like aspirate or inhale into your lungs.
Okay.
So what happens is you do that, it spasms down, and now you drown, right? But what drowning is that it's that hypoxia. You don't have oxygen exchange. You don't have the ability to do any of your bodily functions without oxygen. You start to have, then you go unconscious because your brain needs a lot of oxygen, and it's the first thing that suffers without oxygen. So you become unconscious, and then you don't continue to like go unconscious and start breathing more water underwater.
Yeah.
You just don't breathe because your larynx spasm down.
Yeah,
and
that's kind of, so it's not like the longer you're down there, the more water you're going to necessarily like have in your lungs. Like even if you pass out and then you like start losing breathing mechanics altogether and you've got like brain injury, like it's not like all of a sudden eventually all the water's going to get in there. Like it doesn't really happen that way.
It just doesn't happen. That your body just kind of collapses that down. So two things happen. So one is your alveoli or your lung tissue fills up with water so you can't exchange oxygen there.
Remember those alveoli are those grape-like clusters that are in the lungs, and that's where oxygen exchange happens, right? So it's like a little bulb almost, and then oxygen exchange is happening through the vessels right there. So if we get water in there, we can't exchange oxygen or carbon dioxide in any way.
Another thing that happens is that there's something called washout, and this is a little more technical, but your alveoli or those little air sacs in your lungs have what's called surfactant. Mm-hmm. It's almost like an oily substance that keeps them open, so that when your breathing is easier as you breathe in and out. The water kind of washes that oily stuff away, and those alveoli like collapse. So your lungs almost collapse down too. So now it would take like a lot of force and energy to blow those lungs back up.
It's not just getting the water out of there now. Now it's reinflating the alveoli and
right.
Like
and your lungs are not like a balloon; they're more like a sponge. So imagine that you like wrung out that sponge and it's like collapsed down. It takes a lot more, air or something like that to like span that back out. So that's the mechanism essentially. I mean, it's just hypoxia. I mean, a little more technical, telling you exactly what's going on there. And we can talk a little bit about difference between salt water and fresh water, because sometimes that shows up on EMS students' exams or emergency medicine students' exams and things like that. We can talk a little bit about that, but it doesn't really matter. If we're trying to take it back to basics, it doesn't really matter. The mechanism is hypoxia.
Yeah, and I think the big lesson, like when we talk about dry drowning, and again, all drowning is drowning, but like the idea behind the dry drowning thing is that if you have someone who was under and experienced a drowning-like state, and then you got them out and they're like feeling fine now and conscious, they still should go to the hospital and get a chest x-ray. Because the issue is if you have like residual amounts of fluid down in those alveoli, you can eventually go hypoxic because of the limit in oxygen exchange, correct?
Right.
So that's what they would refer to dry drowning, because like you quote unquote drown on dry land. You know what I mean? But the issue is that like we watch like these lifeguard shows and stuff, or like Baywatch or like Water Rescue, and they like pull them out and they're like, oh, a little CPR, and then they pop, they're like, oh yeah, and it's like, yeah, go home to your mom, like you did great. Like that's a bad idea. Like take them to the hospital, get that chest x-ray, look for that fluid, because they may need to get deep suctioned and things like that.
And that's why we've defined drowning as just drowning, because like all these people need to go. The complications after the fact, and a lot of that goes back to like fluid shifts too. Like you get fluid shifts from the water being in your lungs. They all need to go to the emergency department, get evaluated, probably even admitted. There's some guidelines, and I'd have to look them back up. I didn't review them for this podcast, but there's some recommendations for us as emergency physicians, how long you should watch these people for, what's the time frame for fluid to shift back into the lungs and that sort of thing.
Yeah.
So real quick, I said, I know we want to get more into the dive emergency side of things, but really quick, let me just quickly explain the difference between saltwater and freshwater drowning.
One's got salt. Got it.
What? So because this does show up on exams and things like this, it doesn't really matter. Again, for the sake of how you're going to treat these people, it doesn't change the management, but just having an understanding. So when you inhale or when you bring a bunch of fresh water into your lungs or into those alveoli, into your lung sacs there, right? The electrolyte balance is different between that water and your blood. So your blood has more electrolytes in it. So what happens is that water, that fresh water,
wants to follow the gradient, right?
Wants to follow the
area
gradient.
of concentration.
Exactly. So that fresh water will get pulled into your vessels. So you get what's called like hemodilution, or basically your blood almost becomes more water and and less electrolytes. But what happens is that fluid does get pulled from your lungs into your blood vessels. So that's an example of like later on, as your body's trying to fix that, it might push that back into your lungs and you could have problems later on. Which is, that's where like dry drowning comes in. We're like, oh, I'm on dry land. Why am I drowning? It's like, well, now the fluid's shifting back because your body's trying to balance it all out. And all of a sudden your lungs are filling up with fluid from before that it absorbed, and now it can't.
That's cool. I didn't know that. That's
so
cool.
It's super interesting. So, but with saltwater drowning, the concentration of electrolytes, that salt, is much higher in the lung when you inhale it. So more fluid goes from your blood vessels into that tissue, into that alveoli. So you get even more fluid in there from your body, so they get pulmonary edema or even more fluid.
So maybe like
buildup.
worse stuff initially, but not necessarily as much of a risk later.
Exactly right. And again, when it comes to management, basics of, we're treating hypoxia, asphyxiation, and the management is going to be the same. But just so that people understand kind of the nuances between those two.
Yeah. Nothing I can do. I'm not going to cut open the chest and...
No, right. There's not like any special fluid or
yeah.
anything we can do to change that. It's more of the big thing we need to think about is like dirty water. So people who drowned in dirty water, whether it be like a polluted lake or that kind of, that's where we need to consider other things. These patients are at much higher risk of infection, bacteria, because they're not only bringing in water in their lungs, they're bringing in that bacteria and stuff. So those patients can have a lot worse outcomes because
later
of those other factors. Yeah, exactly.
Sure.
So
cool. All right. Well, I said we were going to talk about dive emergencies, so let's get to that.
Sorry.
real quick. No, it's fine. So again, have those considerations. Kind of know where your hyperbarics are. Understand that we're going to probably be dealing with near drownings and things like that, because I think that traditionally we talk about drowning, we're talking about like someone on the surface who's like sputtering and then, oh my gosh, and then they're still near or at the surface. When we talk about dive emergencies now, we talk about people that might have ran into these issues at 100 feet, so they're completely submerged. They're down there. We're dealing with cold exposure, depth exposure, things like that. So before we can get into the individual emergencies, and there's really only like 3 big things you're going to see that are dive. I shouldn't say that are dive specific, but
the ones we want to focus on.
Yeah, the ones we want to focus on, because there's other things as well, like oxygen toxicity, things like that. But those are kind of a little bit more, I think, obvious and understood. These are the basic specific ones. We're going to talk about decompression illness, or the bends. We're going to talk about nitrogen narcosis, which is something you experience when you're diving. And then we're going to talk about air embolisms, which is probably, in my opinion, the biggest threat to life. The biggest emergent threat to life is this air embolism. And I think we think the bends because it's just what we attach to diving. Oh, someone gets the bends. But we'll get into it. So before we can understand any of that, though, we have to understand diving science in general. All right. And don't be scared by the word science. It's pretty simple. So you and I right now, we're on the surface. We're under atmospheric pressure. So there is a pressure of the environment that is pushing down on us, our tissues, our cells, everything, right?
And I thought that was just my depression, but it's just actually
that's extra. Okay. So no, we're under what's considered 1 atmosphere. So we say the surface, we're at 1 atmosphere of pressure. And what that means is when I breathe, I'm breathing in mostly oxygen, nitrogen, and maybe a little bit of carbon dioxide and other gases. All right, carbon dioxide in the environment is not prevalent, okay? It's mostly oxygen, nitrogen, and some other passive gases. Mostly oxygen, then nitrogen. So what happens is when we breathe in, the CO2 that happens with breathing mechanics is created in our body, right? It's the byproducts of our body's function. So we breathe out that CO2. So CO2 in our body doesn't really change in in volume or in concentration. It's the same amount of CO2 in there, whether we're at depth or we're up high, right?
So if I'm breathing it out, because we're creating and breathing it out.
Yeah, I'm creating and breathing it out. I can be creating and breathing it out down there, or I can be creating and breathing it out up here. The concentration isn't changing in any way. So, and we'll go over that in a second. The other ones we're taking with us, we're breathing it in. That's going to start to change things. So first, let's kick off some notions here. We don't breathe oxygen concentrations. We typically don't breathe oxygen concentrations when we scuba dive. We have a compressed air. It's just a tank of air that we got at the surface. We pumped it in there. We pressurized it. It's in a tank and we take it with us. It's not like people will be like my O2 bottle. It's not an O2 bottle. If it were O2, you'd be dealing with oxygen toxicity because you'd be breathing basically.
So when you say compressed air, because I think a lot of people think air is oxygen, you're talking about air as in like the mixture of oxygen and nitrogen and some
the CO2
carbon
and the passive
We
gases,
took a bunch
right?
of this atmospheric
air we're breathing right now.
Pumped it into
we shoved it in the tank, right? So there is instances in diving where people use what's called nitrox, and it is higher concentrations of oxygen, but it's still air. It's not dangerous concentration. They might put like 3% or 5% oxygen in there. They put a little bit more. And the purpose of that is so that it's easier for you to dive because you're breathing some oxygen, so you can stay down longer, but only at shallower depths. And we'll talk about why. So right now we're breathing 1 atmosphere, right? If you filled up a balloon up here, and then you started diving down with it, as you get deeper and deeper, the pressure is going to increase on that balloon. So the gases inside that balloon are going to get compressed, and you'll see that balloon start to shrink down.
And that makes sense too, because I think people understand that when you think about these movies you watch with submarines, as they get lower, the pressure, like they start to like crank these, you know, it starts like you're not only dealing with the pressure of the air in the atmosphere, now you're dealing with the pressure of the water. And as you get lower, there's more water above you. That pressure's higher. That sort of thing.
So atmospheric pressure increases and increases. And if you want to know the exact math with it, about every 33 feet or 10 meters, about every 33 feet, you add another atmospheric pressure. And what that basically means is that exponentially, you're compressing this gas more and more. I have that balloon up here. I take it down to the second atmospheric mark. I take it down 33 feet. And now all of a sudden that gas has been compressed to 50% of what it was. So the balloon shrinks because the concentration and the volume is going down. So now I want you to imagine that we breathe 10 oxygen right now in one breath. I breathe 10 oxygen in with one breath. And I go down to atmosphere 2 now, or 3 or 4, and I get deeper and deeper. Now I'm still breathing because I'm breathing out of compressed air in my backpack, right? Mm-hmm. I'm breathing out of my scuba bottle. I'm still in one breath breathing, say, 1 liter of air. But instead of having 10 oxygen now, because all of those particles have been compressed, I'm now breathing like 40 oxygen. Mm-hmm. So suddenly what starts to happen at depth is we're breathing fine, everything's good to go. We're not breathing more volume of air, but we're breathing more concentration of the particles that are in that air. Does that make sense? So now there's way more oxygen and there's way more nitrogen. And there's a little bit more CO2 that's in my system that I don't need. So what starts to happen is we get too busy down there. If we spend too much time.
So like from the standpoint of the vessel, right? So I'm inside the body and I'm the blood vessel and I'm exchanging oxygen and stuff. So it's like you said, like 10 molecules of oxygen were coming by me and now I've got like 40 and I'm still just exchanging and doing what I normally do, but I don't need necessarily all this extra.
Yeah, and we can go deeper into like the solubility of oxygen versus nitrogen. We won't. We could though. No, but like nitrogen tends to just kind of like sit in the tissues. We don't use nitrogen. It just sits in there. And usually we're not dealing with a lot of it. But as we start to get that compressed, now we have a ton of nitrogen and it has nowhere to go. Oxygen isn't that soluble. It usually has to bind to hemoglobin to kind of stay in our system. But once we fill that hemoglobin, there's just extra oxygen now that we don't know what to do with. This starts to fill our systems. But we're under pressure too. So our volume is under pressure. So everything's kind of hunky-dory down there for a while.
Okay.
The problem that happens is now let's take that balloon. We've compressed it. We're adding air to that balloon through an oxygen or an air canister now, right? So we're adding volume at way higher concentrations. So there's too many particles. Now I start to surface and I start to come up. If I come up too fast, now the volume's going to expand dramatically. And now I'm going to have all of those particles needing to try to escape. All right. So now if I go down to a depth with a balloon and fill it up with air at that depth, and now I start to surface, that balloon's going to pop. The volume's just going to increase greatly because we have so many particles and now they're all expanding. They're going to burst that balloon. So we don't want to be that balloon.
Right, we don't want to be the balloon. But not only is the balloon expanding, but each molecule of oxygen, nitrogen, they're all expanding as well, right? They're all almost like little balloons within a balloon that would be us.
Let's put it this way. I breathe one, let's say, liter of air up here. I take let's say one breath. I take one breath of air. I get 10 oxygen from it. I know that if I take a breath down there, I get 40 oxygen when I take a breath. Now I skyrocket up and I get up here. Relatively, I have 40 oxygen now, and it has to expand to 4 times the volume. Mm-hmm. That oxygen has to escape. And what that does is it creates bubbles, and those bubbles need to be able to escape out of our body tissues. So they get lost into the tissues, they go into the brain, they do all sorts of things. So there's 3 things that we bump into. One is called nitrogen narcosis. Well, we'll start with decompression illness. One is called the bends, or decompression illness or sickness. Okay, this is when those bubbles, because we're coming up too fast and the volume's expanding at a higher concentration, we're dealing with nerve issues, we're dealing with blood and lymph vessel issues, and we're dealing with excruciating joint pain and a risk of clots because all these bubbles are starting to escape.
So, and when you say escape, into the tissue.
Yeah.
Like they have to eventually work their way out of the tissue, which
is they how do we get rid of it?
How do we get rid of it?
So normally we just breathe it off, right? Because we're at normal concentrations. Now we have so much extra that it has to get going. What a safe scuba diver does is they surface very slow. You go up at 1 foot per second, really, about 1 foot per second, and then you have safety stops where you have to stop and breathe normal.
So you're breathing.
You give your body time to let that air escape safely.
And you're getting rid of all the stuff. So your body is taking all these bubbles and things, and they're eventually putting it into the lungs so they can escape off.
Yep.
Right? That's how your body's going to eventually release these.
Right.
If it doesn't release it that way, they will eventually just going to take time. And in the meantime, you've got all these bubbles in your tissues and things like that.
And then, so a safe diver, they have these safety stops, and then they do a 15-minute or a 5-minute safety stop at about 15 feet. They breathe off as much as they can. They come to the surface. They still are going to have extra concentration in there, and that's why you can't jump right back in the water and go to depth again. You got to wait, and there's usually a time frame before you can dive again. And we base this off of dive tables that we look at before we go down. We plan our dive, we dive our plan, and we look at what's safe to do. That's how a normal dive should go. What happens is if there's an emergency, and I'll give an example. You said you were diving with Lindsay. Mm-hmm. If she had gone down to 100 feet, lost that mask, and then now all of a sudden she goes, what's my natural reaction? I'm going to swim up as fast as I can because I need air. She's cranking through 3 atmospheres of pressure. All of those bubbles are going to rapidly expand, and now we're having issues of them getting caught into the joints and mm-hmm. becoming unsafe for us, right? Because of the concentration. So how do we fix it? Well, we're not going to take them back down to depth to let them breathe it off. We're not going to do that. That's dangerous. We're going to have to simulate the pressure changes in a decompression chamber. Okay, and that's why we need to take these patients, and they're going to have symptoms of the excruciating joint pain. They might have neurological symptoms. It's going to be pretty, they're going to be sick. So if we're dealing with that type of sickness, and they just dove, we need to take them to a hyperbaric chamber where they can go through a decompression chamber, and we can decompress them over time. And sometimes it takes hours.
So basically you're putting them in a hyperbaric chamber is basically putting them in a chamber, and you're simulating as if you took them down. You're increasing the pressure, that sort of thing. Now, not everybody needs that though, right? So I'll give another example is you and I were diving just this past winter. We were doing those caves, they're mines, but we were diving in these mines, and then we did our safety stops, and we came up slow like we normally do. We're pretty good about that. But then back at the hotel that night, I started getting really bad shoulder and back pain. And I was like, man, what's going on? Maybe my tank was too heavy. And then I was like, oh no, this is I'm a mild version of the bends. I'm getting that nitrogen, oxygen expanding in my tissues. It was painful. And my body eventually breathed it off, but I didn't need to go to a hyperbaric chamber.
Right.
So what about people who, like I said, not necessarily are in those emergent situations where they're having terrible pain so does that make sense? So what situations would you, as an EMS provider, take them to a hyperbaric chamber versus how else would you treat
So
them?
it's
hard.
It's
right?
a hard question to answer because your professional statement is always going to be like this patient needs transport and they should get the best of the best no matter what, right? There's a little bit of like practicality in it. Like what you were experiencing was so minor and there was no neurological symptoms involved. So we're concerned about these bubbles getting into the brain and interrupting brain function. Like that's the biggest concern. Okay. If you were experiencing severe pain in any way or anything like that, we'd want to move. But this is why it's normal for you to be pretty exhausted after a day of diving because your body is working to push all of this tissue, all of this all of these cells and these molecules, all these gases out of your system, and it's kind of in overdrive working. And that's why it's super fun when you're diving, but afterwards you get the best sleep of your life because you're just exhausted. So I think, as a rule, try to be familiar with if you're there, then I would say it was serious enough for them to call 911. Well, we should probably transport.
Fair. If someone calls 911 for these
on.
symptoms, EMS should assume that, hey, maybe these people need, and obviously they can call medical direction and control as well. Hey, should I take this person to this other facility? Because that can always happen later as well. If you get their pain controlled and make sure their oxygen levels are okay and then get them to an emergency department, I can decide, you know what, this person probably should be taken to a hyperbaric chamber. Let's transport them. Yeah. So we can make those decisions together. But I think you kind of answered the question too. It's that neurological symptom, right? Yeah. So that's the worrisome, real worrisome one where, hey, if they're showing signs of these oxygen and nitrogen bubbles have expanded in the brain and they're having neurological symptoms like numbness, tingling, weakness, slurred speech, stroke-like symptoms essentially, then obviously they said going to a hyperbaric chamber is going to be probably your best bet there.
So this is what brings us into what I think is the most serious dive emergency that you can deal with.
I just took a bunch of Percocet. That worked fine.
No, you didn't. Don't tell me. So is an air embolism. Okay, so worst case scenario here is same rules apply. We're coming up. It's usually because we're coming up too fast or we stayed down too long, right? And if we're coming up too fast, that the air is expanding, the volume is expanding, and so the concentration is needing to escape, and that's going to escape through air bubbles. If those air bubbles lodge in our vessels, we can end up with an embolism. And we talked a couple podcasts ago
episode
about
2.
Thrombosis versus embolism and what that is. But basically, an embolism, it's a blockage in the vessel, right?
It's any foreign body or foreign material like a nitrogen bubble or an oxygen bubble that lodges in a vessel and decreases and blocks blood flow. Right.
So if this nitrogen lodges in our vessel and cuts off blood flow, we're dealing with embolism-like injuries. So this could be a pulmonary embolism if it blocks off blood flow to our lungs, and now we spontaneously start to stop breathing. I don't know what I'm saying. Yeah, we got that. Then there's we can have like an embolism that would cause a stroke in the brain, right? If we block off blood flow to our brain, we could technically have an MI from this, right? An air embolism blocking off
a coronary
flow
vessel
to our heart, coronary vessels, or we can have deep vein issues, things like that. Big serious issues where circulation's cut off. So if that's the case, it's high flow oxygen. We got to get them to a hospital, probably the closest one, so that you can work on getting that air out. And it's probably going to be in another hyperbaric chamber.
Yeah, especially for something like a pulmonary embolism or a stroke due to a dive emergency, they're going to have to go to hyperbaric in some way, shape, or form because there's no other way for me to get rid of that. Yeah. They have to be taken back down to depth to shrink that bubble back down and then let the body eventually kind of blow that off and that sort of thing.
So as always, what we take away as paramedics is it's not that we're doing crazy advanced techniques. It's that we understand advanced pathophysiology and then understand the simple solutions to that. So what we need to be looking out for is, okay, do they have these types of symptoms? Am I expecting an embolism? Am I suspecting an embolism? Am I suspecting decompression illness? If I am, the only thing that we do treatment-wise is, do your 12-lead, do your IV, do your basic care, your vital signs. We want to flow high flow oxygen to them 100%. And you might think, well, wait a minute, I thought they've got too much bubbles in them. But what we're trying to do in this is displace all the bad stuff, all the nitrogen, all the CO2, all that stuff that's in their system. So we're trying to displace that with healthy oxygen. We know we can at least use the oxygen. And we know that it's not at high concentration or at high volume at 1 atmosphere. So this is safe to do. So we're going to high flow oxygen and we're going to transport to a hyperbaric chamber ready facility.
Yeah. No, absolutely. Another thing, too, from that oxygen therapy standpoint is that your body is working to push these gases out. The way your body works is through metabolism, which is with oxygen. So the more oxygen, that like you said, it's useful in the sense that our body's working. So giving it more oxygen is only going to be helpful in that sense. So
there is one third thing that
one.
I want to cover. Just when you're down there, what can happen sometimes is what's called nitrogen narcosis. So we talked about how our body uses oxygen, but there could be extra oxygen, extra concentration, and our body is giving off CO2, so we don't have to deal with increased volume or concentration of CO2 because it's a byproduct. Nitrogen doesn't get used in the body. So as we go down, if we had a liter of nitrogen in our blood vessels and we go down, we're breathing air down there.
And air has nitrogen, so we're breathing some nitrogen in that we're not using. Now we're breathing
more nitrogen because a breath is now taking 4 times the amount of nitrogen in because it's so compressed. Now we have a bunch of useless nitrogen in our system, and same thing happens. It has to start going places. And if it starts getting into the tissues, especially the tissues of the brain, we start to experience something called nitrogen narcosis. And this is like getting drunk for some people. When you're down below, all of a sudden the high levels of nitrogen that's in your system is causing you to feel loopy. And it starts with that. It starts with loopiness or silliness, or maybe for some people it's an extreme fear all of a sudden, like an unnatural fear. And it kind of depends on how your body responds to it. So some people have this happen at 2 atmospheres, and some people have this happen at 4. It really depends. So you really have to be paying attention when you're diving. I'm always watching you to see if you're acting sillier than normal, right? And you should be doing the same for me. But those high concentrations,
I'm just naked. You're like, oh no,
exactly,
nitrogen narcosis.
Right? So and that's the thing is my experience in teaching. As a dive master, like, you got to watch this. Sometimes they get a little loopy, but loopy could be, ha ha ha, look, I took my mask off, or I took my regulator out, right? So constantly be kind of watching this. This is something that can happen. We call it getting narked. So if you ever hear divers talk about getting narked, it is getting high concentrations of nitrogen. You get a little loopy. It can be extreme fear, but eventually with too much nitrogen in the brain, we can start dealing with stroke-like symptoms in the sense that we have lack of blood flow. And
treatment for this is basically just going to be, like, if you start to see your dive buddy or yourself, you start experiencing these kind of things, is to come up, right? Is to come up so that the bubbles shrink back down, and then let your body breathe that out before you try to go down. Exactly. And really the recommendation is, if you ever get to that point where you or your partner is experiencing symptoms of nitrogen narcosis, just stay up. You know what I mean? Like, probably don't go up and then try to go back down. I mean,
know your limits. Don't get back down there. You're pretty much done for the day, right?
I actually think back to when we were diving those mines. So this past winter, Jason and I dove these mines where they're, what kind of mines were they? I forget exactly.
It was Bonterre mine, it's called. Yeah. But it's basically, I don't know what they were mining.
But anyway, it was this huge, they'd pumped all the water out of this mine. And this mine had been going on active for like 100 years. And then they abandoned the mine. They didn't need it anymore, so they just let it fill back up with water. So now you can dive through these mines and and it's dark and it's super cool. But it's
cave diving and it's sweet.
It's really cool. But I actually been thinking back now, and I remember at a point where, like, I got real panicky. And I thought to myself, like, well, it's, it's dark and it's a cave, and I was able to relax. But I'm wondering now if maybe I was experiencing, you were saying that fear component.
And that's half of it, is just going in equipped with the knowledge that, hey, this can happen to me. And if I start feeling some way that feels off, I need to be able to just recognize something's wrong. And what's the solution to that? Come up slow. It's as simple as that.
Exactly. Cool.
So that covers what I wanted to cover today. Just to review, we talked about scene considerations when we're dealing with dive emergencies. We talked a little bit about the mechanics of drowning and why we don't really specify different types: dry drowning, wet drowning, partial drowning, all that stuff.
Drowning's drowning.
Drowning is drowning. We talked about some diving science. We understand now atmospheric pressure, how gases become compressed as we go deeper, and how that affects not the volume of the gas, but the concentration now that I'm breathing at depth. We talked a little bit about how we would decompress naturally in a dive by coming up slow and doing safety stops. And then we talked about 3 major dive emergencies, one being decompression illness. That's that extra gases that are expanding rapidly and now escaping the system. They can get into the tissues, cause things like joint pains, neurological issues, blood and lymph vessel issues. And then we talked about air embolisms, if one of those air bubbles lodges and cuts off circulation, big concern. And nitrogen narcosis, where when you get a little bit loopy, going down for too long and hanging out down there. So
yeah, excellent. No, great. So again, you guys, just a reminder, this podcast will be available for continuing education credits for EMS personnel next month. So every month after the podcast release, those will be available on American CME's website for continuing education. This one for sure. I mean, we've covered a lot of really good pathophysiology and stuff here, so this will be available there. Once again, our sponsor today is CPR for All, doing some great work there, so we appreciate them being our sponsor today. But thank you guys for taking the time, and we will see you next time.
Stay sweet. Hey guys, hope you enjoyed the episode. If you're an EMT or medic student, or an advanced EMT student, or an instructor of those students, we have a program just for you. With Sights and Sirens and our Emt Prep Program, you get video lectures, over 15 hours of really vetted, great content to help you through your program and help you prepare for the test. Check it out at www.sightsandsirens.com.